Hi, everyone. Welcome back and good morning. Today, we're joined by Dr. Brandon Webb to give our weekly COVID-19 update around the state of Utah. We're joined after a holiday weekend. A lot of people had yesterday off, so we wanted to discuss our case trends and what's been happening in the community since the last time we spoke. Brandon, it's nice to see you. Thanks for joining us.
You too, Amanda.
So I want to start, as always, with case trends and go over what's been happening since the last time we spoke. These are yesterday's case numbers, just so everyone is aware. But as of yesterday, the state of Utah has a total of 324,919 cases. Yesterday's daily case counts was 1,082, which brings our 7-day rolling average to 21.1% positive rate. Our deaths in the state of Utah totaled to 1,500 as of yesterday, with 7 total deaths reported. Our hospitalizations are at a total of 12,576, with 568 reported yesterday. Our vaccines are also reported at 1,068, 908 total. And as always, that number can sometimes be a little bit delayed depending on reporting. But I want to talk about how our hospitals and ICUs are doing first. It seems like our case counts are coming down, but that hospitalization number is still pretty much the same as it was last week. Can you walk us through what that means?
Yeah, absolutely. Well, the good news is that we are now seeing a modest decrease in our community transmission and in the percent positivity after the holidays. So we did see and expected to see a spike after the holidays. And really the takeaway there is continued emphasis on gatherings as the most important place of spread. And that's what we saw with the holidays. And then following the holidays, we did see an increase in both the percent positivity and the community transmission rate, which has peaked, and we're encouraged by the modest decrease. But remember, admission to the hospital lags behind community transmission by 2 to 3 weeks to give time for people to be exposed, develop symptoms, progress through their symptoms, and unfortunately those who are higher risk then become ill enough that they need to be admitted to the hospital. And then we see a much flatter curve with the hospitalization and especially the ICU rates, because once in the hospital, patients tend to be there for several days if they have moderate and severe, and if they're in the intensive care unit, often they're in the hospital for 2 weeks or more.
And as far as our healthcare workers are going, it's been almost a year. I know that the first case for Intermountain that reached Intermountain Medical Center was the last week in February. I remember where I was when that happened, but it's almost been a year since this pandemic has started, at least in the US. How are healthcare workers feeling? How are you feeling? What's the general mood and energy level of people that are dealing with this?
Yeah. I think my healthcare colleagues are all working as hard as they ever have. Our hospitals are as full as they ever have been. We're bumping right up against the peak that we've seen for the pandemic. And we expect, the modeling suggests that slower curve should expect to have full hospital numbers through February and beyond. And I think that most of the healthcare workers that I work with every day have settled into the reality that that's the case. They're working hard, they're doing their job, they're providing great care for the patients with COVID and those who are admitted with other conditions. But certainly there's fatigue. And I think everyone's looking forward to seeing continued progress in terms of community transmission, which then drives lower admission rates.
If you had a magic 8-ball, could you predict when you think it could ease up potentially for healthcare workers in a hospital setting? I know that's a tough question.
Yeah, it's all dependent on what happens in the community. And we're looking forward to a stretch where we don't have major holidays coming up. We do have our institutions of higher learning that are going back. So that's something that we're going to need to keep a close eye on. And of course, schools are back with Salt Lake County going back to school as well. So we're going to really need, as a community, to continue to pull together and finish strong here. And that will that will define what happens in the hospital and in the ICU, how we are able to respond during the next 6 weeks as we come out of this winter period.
There's also been a lot of reports around the new strain. The UK strain is what a lot of people are referring to it as. And there's been reports that this is going to be the dominant strain in the US by March. What are your thoughts on this, and what are the potential implications for this strain if it does become the dominant one for a hospital system?
Right. I'm glad you asked, because I think that's top of mind, and it should be. It's concerning, and it's a wake-up call that we need to be especially vigilant and effective in doing the things that we know work to very rapidly bring down the community transmission rates. And if you don't mind, I'll try to explain why that is. Coronaviruses are among the biggest viruses in the viral family, and they have really large amounts of genetic material, 23,000 letters in their genetic code that have to be duplicated every time a new virus particle is made. And because of that, they're prone to making mistakes in their genetic code. That's something we've known all along. And if you think about every cell in a person who's infected can have thousands upon thousands of viral particles that are reproducing. And then there's thousands to millions of cells in the human body, and then millions upon millions of cases worldwide. That's a lot of replication going on worldwide. And so it's not surprising, in fact, it's inevitable and predictable that with all of that replication going on, there's going to be some errors in the genetic code. And most of those, in fact, 99.9% of those errors are not helpful for the virus. They result in some change that makes the virus non-viable. But every so often and rarely, those mutations result in a change in the proteins of the virus that actually make the virus more able to cause infection. And those strains are what we're now seeing. Now, it's good to know, Amanda, that these new strains, while they're emerging and they're in the news right now, that's also not new. We've been seeing new strains emerge since the pandemic began. And most people don't realize that the dominant strain worldwide right now is not the Wuhan strain. It's actually a strain that originated in Europe in the late spring. So these strains do develop, and they outcompete other strains that are not as capable. And that's what we're seeing now. This new strain, well, there's really 3 new strains that people have seen in the news. There's what's known as the UK variant. There's also the strain that's been reported in South Africa and other places. And then a new strain that's been in the news just this weekend that's been identified in Brazil. These strains are concerning because the mutations in these strains are in a specific place on the spike protein. And that specific location on the spike protein is called the receptor binding domain. And it's the very specific part of the spike protein that interacts with the receptor on human cells and allows the virus to hijack and climb aboard human cells. And those mutations in the UK, South African, and Brazil variants have changed the protein just slightly to make it more sticky, if you will, to allow it to stick to the receptor more easily, and have changed the shape slightly of the protein. And because of that, it does appear likely that the UK variant with the N501Y mutation is more able to infect human cells. And so I think the CDC projections are correct. They're in alignment with what we've experienced so far. And like I said before, they really are a wake-up call that more so than ever before, we need to rapidly do everything we can to bring down the community transmission rates, because the fewer the cases, the less replication going on, and the less chance these new variants will have to dominate and predominate.
So is this similar to kind of what the flu does every year in terms of mutating and changing a little bit? Is that kind of what COVID-19 is doing now? It's kind of adapting and changing to its environment?
It's somewhat similar. Flu has its own genetic tendencies, and those are very well known to us now. You know, we know every year that we expect to see new variants of the flu, new strains. Coronavirus is similar but unique in some ways because of the size of its genetic code. And you know, its mutations are really random, but when there's so much replication going on globally, and even in our own community, the chance that those mutations randomly occur and are able to confer an advantage increases. And as you saw over the last week, our experts at the Utah Department of Health, who have some excellent sequencing capabilities, are able to do surveillance for these mutations, and they have identified that the UK variant, as predicted, is now in the state of Utah.
And is there anything different that the general public should be doing in terms of this new strain? I've read some conversations around people saying we should probably all start wearing masks outside when we're on a walk and we could potentially interact with someone else, or be more vigilant about wearing masks indoors if we're around people who don't live with us. Do we need to adjust any of our habits and behaviors from the last year for this strain?
I think the only adjustment that needs to be made is to dig in and continue to do the things that we know are effective. Masking when social distancing isn't possible, and indoors, limiting gatherings as much as possible. Remember, those gatherings, especially indoors, and especially when masks are not worn, are the most important driver of transmission. Finding ways to socially distance and being creative about interactions with others, being creative about our work environment, and in general, just being vigilant with the indoors, and continued hand washing and the things that we've been doing all along. We know those things, they do work, and we see those borne out with the numbers. You know, we can very clearly see that when we're less careful as a community, we see spikes, and when we hunker down, we can be very successful at controlling viral spread in the community. And that's what we need to do now to answer the wake-up call that these new variants are.
We've also been really lucky this year. It's been a very warm winter. Lucky in terms of we can still gather outside. I know other industries are struggling with not having snow, but it does give us the opportunity to have that social connection with people outside more often, which is great. So as we continue into the colder months, hopefully it kind of stays that way and gives people that chance. Somebody asked us the questions around the 3 new variants and wanted to know if there's any new cases that have been identified specifically in Utah, between the UK, the South African, and the Brazil one. Are we seeing that at all in Utah? I know the UK one was confirmed last week, but what about the other 2?
I can't speak to whether the Department of Health has identified any additional UK variants or any of the other 2, the Brazil or the South African. Dr. Dunn and her staff have some really unique capabilities at the Utah Department of Health, and we're lucky that they're able to perform advanced sequencing. And so we do look forward to continuing to work with the Department of Health and look forward to updates from them as they do their routine surveillance. And they are able to sequence hundreds and sometimes thousands of viral isolates or samples every week. And so they're going to continue to do what they're very good at, and do surveillance at the community level and help us stay informed.
There's also been a lot of questions around the flu this year and the fact that we're seeing a lot lower numbers. I know that Intermountain reports to the state around what we're seeing, and those numbers are pretty low compared to last year. Why do you think that is? Is what we're doing working for the flu?
Yeah, I think there's a number of different potential explanations. One is that not all viruses are transmitted identically, and the distancing and the mask wearing and the other things that we're doing certainly help to curb flu transmission. And even on a global scale, we may be seeing less flu making its way around the globe from east to west. The coronavirus may be competing for people who are sick. And then, we've seen an outstanding response in terms of flu vaccination this year, which was much needed. We couldn't afford to have a double hit. So I think that there's a combination of all of the above. Things that we're doing to prevent coronavirus are effective for flu. The global flu behavior is probably modified this year, and flu vaccination certainly helps.
Speaking of vaccinations, I want to just give a quick update on the COVID vaccinations. First, a question from a reader. How long do we think that the COVID vaccine is going to provide people protection?
Yeah, it's a brand new vaccine, and we won't know for certain until we've had time to observe and check immunity longitudinally going forward. We are encouraged that the vaccine stimulates a very robust immune response. And the clinical data does suggest that because the 2-dose format of the mRNA vaccines stimulate a very robust response from the immune system. And because of that, we do expect that the vaccine should give at least 9 to 12 months of immunity, and perhaps more in some patients, perhaps less in others, depending on the health of your immune system. But that 2-dose vaccine series does appear to have a very effective response. And time will tell as we get further into this, how long that immunity lasts beyond that 9 to 12 months.
Another question that we've gotten a lot is around the potential side effects of the vaccine. There's been some reports of people experiencing flu-like symptoms after getting the first dose or even the second dose. Are these normal, and what can people potentially expect to happen?
Yeah, they're absolutely normal, expected, and actually reassuring. It has to do with the immune response that the vaccine is generating. People are oftentimes surprised to hear that many of the symptoms that we experience when we have a viral infection like COVID or influenza are actually not from the virus. They're actually collateral damage from our immune system responding. And some of those symptoms include fever and body aches, headache, fatigue. A lot of those symptoms are attributable to the immune system doing its job. And so after vaccination, and especially after the second dose, which is a booster for the first dose, we expect to see those types of immune-related symptoms. In fact, they're very common. 30% of people will have body aches and chills and fatigue. And that's expected, normal, and safe, and does not indicate that one becomes sick or has acquired COVID from the vaccine at all. That's the expected response to the vaccine.
If you do experience a fever or body aches or anything like that, I've kind of heard that you maybe shouldn't take ibuprofen or something like that. Is there any truth to that statement? Can you take a over-the-counter pain relief if you need to, or should you not if your body's experiencing that after the vaccine?
So especially for the first dose, our experience with childhood vaccinations suggests that if we do everything we can to allow the immune system to respond robustly, we get a better response. And so with the first dose of the vaccine, if you can avoid taking ibuprofen and Tylenol, that's recommended. The second dose, like we mentioned, the symptoms are often a little bit more robust, shall we say. And again, generally don't last long, 12 to 24 hours. And if you can time it so that you can rest and recover and don't have to take Tylenol and ibuprofen, that's great. Although it's not dangerous to take ibuprofen or Tylenol. There's some hypothetical that you can get optimum performance from the vaccine if you can hold out without those.
And are we starting to see any issues around the state or maybe in the US with people who are 70 plus getting the vaccine? I know that yesterday in Salt Lake County, they started vaccinating those people. Have we seen anything that we need to be worried about at all?
The biggest consideration for vaccinating our senior population is that we know that they don't respond as well to the vaccine. Vaccine effectiveness in the elderly is expected to be lower, up to 30% lower, and we know that from immunizations, including influenza and others. So we need to remember that even as we vaccinate our most vulnerable senior populations, they may not have full immunity from the vaccine, and we need to still be very careful when we're interacting with them and when creating policies around infection control.
Another question for you too, say that you have both doses of the vaccine and then you become exposed to someone who tests positive for COVID-19. What sort of quarantine self-isolation guidelines should people be doing in that case?
Yeah, it's important that we continue to maintain our same quarantine practices because the vaccine is tremendously helpful, but not perfect. We're very lucky that the vaccine effectiveness that we saw in those clinical trials was so high, but everyone's different. And the protective benefit of the vaccine does vary from person to person. And so if you've been vaccinated and are then exposed, it's still highly recommended and very important that you follow the same quarantine because it's still possible that you could have a low-grade viral infection, perhaps asymptomatic or pre-symptomatic, and then inadvertently spread it to others.
So wearing a mask, doing these public health measures is something that it seems like we're going to keep having to do, at least until we get a little bit further along the lines of this vaccination. Which brings up another question. So you mentioned that the immunity or the response for the vaccine right now, we're thinking around 9 to 12 months. Are we going to be revaccinating people before some people even get their first round of the vaccine? How is that going to work? Is there enough data to support that it will be a yearly vaccine yet? Or are we still kind of in that flux period?
Yeah, it's a really good question and one that we don't know the answer to yet. Time will tell, and right now the top priority is getting everyone vaccinated with their first round. And it's important, going back to what you said just a minute ago, it's really important to recognize that the success of a vaccination program is directly linked to how effective our efforts are at the community level for reducing transmission. So the more effective we are at distancing and masking and all of these things, the less we have to rely entirely on the vaccine as we move forward into the pandemic. So the lower the community transmission, the less the vaccine needs to, or the lower the vaccine distribution rates before we start seeing a benefit. So to restate that, the most important thing we can be doing right now while the vaccine is rolling out is finishing strong, doing those community infection mitigation things that do work.
There's also been some reports around monoclonal antibodies and this team of people that are going out into nursing homes and other areas to kind of distribute them. Can you just give us an update on what those are and what they're used for as far as treatment with COVID-19?
Yeah. Isn't it amazing that in 2020 and 2021, we've all become immunology experts and antibodies are at the tip of tongue? Monoclonal just means that this is one antibody and all of the antibodies are identical. Monoclonal antibodies are antibodies like our body makes to fight infection, but they're specifically designed in the laboratory to be very sticky, again, if you will, to a very specific part of the coronavirus, the spike protein. And there's a number of companies that are developing these monoclonal antibody products. 2 companies have brought their products through phase 3 trials and have achieved authorization by the FDA to give those in patients who are not yet hospitalized. And the reasoning behind that is that the early trial data suggests that if you give these early in the course to high-risk individuals, we can potentially prevent COVID-19 from becoming worse to the point of needing hospitalization. So these are drugs that are intended to help reduce our hospital volumes and help people recover more quickly. And at the state level, since about Thanksgiving, we've been working with a team representing all of the major healthcare delivery systems, as well as the rural unaffiliated hospitals and state incident command to develop a process for delivering these monoclonal antibodies to people who need them the most. And that hasn't been easy logistically because these antibodies are a 3-hour-long infusion. They have a small risk of infusion reaction, so they have to be given by staff that are trained to address and respond to infusion reaction. And they have to be given in places that typically serve patients who are receiving chemotherapy. And so obviously we have to be really careful about maintaining access to chemotherapy and still keep patients separated. And this team at the state level's done a terrific job working together, and we've now infused more than 600 patients in just over 4 weeks, and look forward to expanding that even further with this new strike team that's starting to expand our ability to get treatment into the nursing homes.
It's really great to see the state working together and coming up with these creative ways to get these treatments to people. And like you said, it'll be great to see the strike team and kind of what happens from there. My last question for you is around universities and even just normal schools, high school students returning to classes this coming week. Are you concerned at all with university students resuming classes? Is there a potential challenge that this could present for spread of COVID-19?
Yeah. Certainly, we still recognize that 15 to 30-year-old age group is our most mobile and one of our most important opportunities to control transmission. We're very supportive and applaud the efforts that the colleges and universities have undertaken to implement testing and distancing and all of the many measures they've implemented. And even with that, we need as a community to be really cautious as the university age group resumes both their schoolwork, but also their social activities. And especially if you are at higher risk, meaning if you are 75 or greater, if you're 65 and older and have chronic medical conditions, or if you have diabetes, obesity, or impaired immune systems, those people need to be especially cautious about interacting with their college age acquaintances and family, because it is a very important mechanism for higher risk individuals getting COVID and then going on to have poor outcomes.
I know that the University of Utah just sent out a message to their students around testing, which is really great to see. And it's not just those who are living on campus, which I think is awesome. It gives other people the opportunity to kind of make sure that they're safe as they continue about their day, which is great. Dr. Webb, is there anything else that you wanted to mention to us around what's been happening in the state of Utah?
Yeah, I would maybe finish with 2 things. One is just a reassurance. There's been a lot of concern that will the vaccine work with these new variants? And I just wanted to provide reassurance that we're very fortunate that the vaccine designers designed the vaccine to stimulate immunity to the entire spike protein and not just these specific areas where we see mutations. And so at this point, we're still encouraged and reassured that the vaccine is going to work. So that's one. And number 2 is just a reminder to us all that we need to finish strong. We can do this if we pull together. We encourage efficient vaccine distribution, and hand in hand with that, community efforts to stay distanced, to maintain vigilance and wear masks.
Well, thank you, Dr. Webb. That's really great to know and great information for the public. And if you have any questions around COVID-19 and would like to get tested, you can go to intermountain.com/COVID testing. There's a quick survey you'll fill out just to qualify you for a test, which will then allow you to choose an appointment arrival time. We also have an emotional health relief hotline available 7 days a week from 10 a.m. to 10 p.m. It's free for the community. It's a great support tool if you need it. The phone number for that is 833-442-2211. Again, Dr. Webb, thank you so much, and we'll talk to you next time.
Thank you.